Thank you. It's an honor to be here, and I'd like to thank the committee for giving me the opportunity to present at the 10th Annual Weill Cornell Research Retreat. I'm going to talk about early diagnosis research in dementia here in Qatar, and in a moment, Dr. Hanadi, for the first 10 minutes, and then Dr. Hanadi, which is an honor to have here, the director of Rumeila Hospital and Qatar Rehabilitation Institute, who is going to talk about risk reduction in dementia. So, dementia is a progressive neurodegenerative condition, and its prevalence is 5% at the age of 60, 10% at the age of 70, and 40% at the age of 80. Therapeutic interventions for people with early stage of dementia can improve cognition, independence, and quality of life. However, diagnosis of mild cognitive impairment, early dementia, can be challenging due to the insidious onset of disease and the gradual cognitive decline. So I'm going to talk about 4 things: current biomarkers for Alzheimer's disease, limitations, area for improvement, and then I'm going to talk about corneal confocal microscopy, or CCM. That's a non-invasive ophthalmic imaging technique which we investigate as a biomarker for neurodegeneration in dementia. And then I'm going to present the work we've done in the last year where we assess the diagnostic accuracy of CCM to distinguish patients with mild cognitive impairment and dementia from healthy controls. Compare that with brain atrophy, which is the gold standard. So since 2018, the diagnostic role of biomarkers has changed from confirming the presence of Alzheimer's disease to identifying the disease in its asymptomatic stage. And the NIAA recommended the ATNN classification, where A is for presence of amyloid, and that can be detected with amyloid PET or in the cerebrospinal fluid. Then T is for tau, which can be detected in the cerebrospinal fluid again. And N for neurodegeneration, which can be detected by FGD, PET scanning, and brain atrophy in MRI. Now, all these biomarkers are very accurate, reliable, but they do have limitations. Amyloid PET involves exposure to radioactivity. And amyloid positive can also be detected in patients who haven't got cognitive impairment. Cerebrospinal fluid is painful, is invasive, and therefore cannot be taken routinely. Structural MRI, it can distinguish dementia, but it has poor diagnostic accuracy for mild cognitive impairment and early Alzheimer's disease. Now, it's difficult for a patient to go to secondary health care to do a preventative screening test for dementia, Alzheimer's disease, when it's expensive, invasive, or involves exposure to radioactivity. So there is a need for accurate and reliable biomarkers that are non-invasive, simple, and inexpensive. And that is why Bill Gates and the ADDF have committed $30 million to develop biomarkers to better understand how the disease progresses, to more easily identify patients for clinical trials, and to more accurately monitor the response to treatment. An evaluation of the efficiency of biomarkers is based on 4 things: to provide direct or indirect evidence of the underlying pathology of the disease, and to identify those patients with mild cognitive impairment who will or won't develop dementia, reflect disease progression, and therefore identify the benefits of a therapeutic intervention. And of course, it has to be accurate. It has to be equal or more than 80% sensitivity and specificity. So I'd like to talk about corneal confocal microscopy, which generates in vivo images of the corneal nerve morphology. And that can be quantified using a software to reduce inter- and intra-rated variability. Now, corneal confocal microscopy has been pioneered for identifying diabetic neuropathy for the last 15 years. And recently, a lot of work has been done to look at for central neurodegenerative disease with my colleague, Dr. Petropoulos, is going to cover that in great extent in his talk at 12 o'clock. Now, the discovery that there is an association between the severity of corneal nerve damage and severity of cognitive impairment or independence function in mild cognitive impairment and dementia was a major milestone for CCM in dementia research. So in the last year, we focused on looking at the diagnostic accuracy of CCM to distinguish patients with mild cognitive impairment dementia from healthy controls and to compare that with brain atrophy. And so far, we have recruited 36 control subjects, 80 subjects with mild cognitive impairment, and 66 subjects with dementia. And what's important to point out in this table here is that metabolic risk factors and cardiovascular risk factors are comparable between the three groups, so they don't act as confounding factors. Whereas when we look at the cognitive function that was assessed by MOCA, we find that there is a progressive decline of cognitive function in subjects with mild cognitive impairment and in dementia. We visually rated atrophy in the medial temporal lobe, where using the Duara protocol, and we look where 0 is for no atrophy and 4 is for severe atrophy. And the data shows that subjects with dementia have significant atrophy compared to subjects without cognitive impairment and subjects with mild cognitive impairment. However, there's no difference between healthy controls and subjects with mild cognitive impairment. Now, when we look at the corneal nerve morphology, have a look. This is a representative image of a healthy control where the white lines are the nerve fibers. And this is how it looks like on a subject with mild cognitive impairment and on a subject with dementia. And we quantify the corneal nerve morphology by measuring the fiber density, where the main fibers, colored in red, the branch density, which is depicted by the green dots, and the total length of the fibers, which includes the main fibers and the length of the branches, which are colored in blue, if it's clear in the image there. And what the data shows is that there's a significant reduction in fiber density, branch density, and fiber length in subjects with mild cognitive impairment and dementia compared to healthy controls. So when we conducted ROC curve analysis, where we look at the area in the curve, the larger the area, the more accurate the test, what we find that with subjects with mild cognitive impairment, only the CCM, all the corneal nerve morphology assessment can distinguish patients with mild cognitive impairment from healthy controls. And that is shown here with the blue, green, and red lines, whereas with the medial temporal atrophy, which is close to the reference line, it shows that it's randomly, so it's not a good diagnostic test. When we look at for dementia, though, both the medial temporal lobe atrophy and the corneal confocal microscopy was able to distinguish accurately, with high accuracy, patients with dementia, higher than 80% area of the curve. Now, we don't have that much time, but I want just quickly to show you that we also look at the volume of the brain, specifically focusing on the whole brain volume, the hippocampi, cortical gray matter, and ventricular enlargement. And basically, the data shows the same thing like the medial temporal atrophy rating we've done, where subjects with dementia have significant atrophy compared to healthy controls and subjects with mild cognitive impairment. However, it was not able to distinguish between healthy controls and patients with mild cognitive impairment. So to conclude, brain atrophy in MRI and cognitive impairment and CCM show progressive neuronal loss in patients with mild cognitive impairment and dementia. CCM can distinguish subjects with mild cognitive impairment from those with normal cognitive function, but not brain atrophy MRI. We're going to focus in the future to determine whether CCM can differentiate subjects with amyloid pathology using amyloid PET or Alzheimer's disease hypometabolism pattern using FDG PET scanning in subjects with mild cognitive impairment. We're also going to assess the association between corneal confocal microscopy measures and plasma amyloid beta and neurofilament in collaboration with QBRI. And finally, using longitudinal studies, we're going to determine the prognostic ability of CCM for progression of disease in subjects with mild cognitive impairment by determining whether individuals with MCI and significant corneal nerve loss are at high risk for progression of disease. At this point, I'd like to thank for your attention. And this is our group where we won an award in 2017 for the dementia study. And I'd like to leave you next to Dr. Hanari. Thank you.